My name is John Archidiacono. I'm president and CEO of the Health Museum. I don't know if you know that much about the Health Museum. You've seen a little bit of it as you walked in the doors. I don't know if, did y'all notice some kids out there? So there we go, buses, lots of buses. This is actually not a typical day here at the Health Museum, but it's somewhat typical of having a lot of kids here. So in addition to the exhibits you see out there, we have field trips from different schools that come in here. We also have educational classes, and we kind of play a unique role in that we are one of the only institutions in Houston that is a Smithsonian affiliate. We're also really the only health museum in the country. There is no other health museum that's focused on health and wellness like we are. Our mission is to really empower people to live healthier lives. And that's what's so exciting about being here today and collaborating with the Women's Fund, a great organization like that, and having Dr. So we're excited for you guys to hear him. I'm going to introduce Linda Rhodes Riggle, who is the executive director of the Women's Fund, and she's going to give you a little more information to get us started. Come on up.
Thank you, John. I'm no longer a Riggle. He's known me for three decades. So I'm the executive director at the Women's Fund, and we're so pleased that you're here with us today. We are so excited to be partnering again with the Health Museum, as well as Baylor College of Medicine and the Dan L. Duncan Comprehensive Cancer Center to bring you today's Doc Talk. It is an honor to be in the only Smithsonian Institute endorsed museum in the district. And I want to tell you just a little bit about the Women's Fund. We are celebrating our 40th anniversary this year. We are 40 years strong. And since 1979, the Women's Fund has been focusing our efforts on empowering Houston area women and girls to be advocates for their health and wellness by providing free publications, which we have outside, curriculum-based classes, workshops, and lectures like today's Doc Talk. In 2018, we had an incredible year, and we're well on the way to having an incredible 2019. Last year, we served almost 12,000 women and girls in the greater Houston area and distributed close to 8,500 of our free publications, primarily in underserved and at-risk populations, neighborhoods in the greater Houston area. Now, I'm going to turn the mic over to Deborah Stewart, our MC today, so she can introduce the topic.
Let me get your stuff right here. So our guest speaker today is Dr. Andrew Sikora. He is the Vice Chair for Research and Co-Director of the Head and Neck Cancer Program at Baylor College of Medicine. He's also an Associate Professor of Otolaryngology and a member of the Dan L. Duncan Comprehensive Cancer Center, which is one of only 3 NCI-designated comprehensive cancer centers in this state. Dr. Sikora earned his MD and PhD in microbiology and immunology at the Albert Einstein College of Medicine in New York City. He then completed a residency in otolaryngology at the New York University, followed by a clinical fellowship in head and neck surgical oncology and a postdoctoral fellowship in cancer immunotherapy at the UT/MD Anderson Cancer Center in Houston, Texas. Dr. Sikora's research focuses on understanding and reversing mechanisms of tumor-mediated immunosuppression, the immunobiology of HPV-related head and neck cancer, and the development of novel in vivo I knew this was going to be hard.
You're doing great.
Models for the study of tumor biology and therapeutic response. He is the principal investigator of observational and therapeutic clinical trials designed to understand the impact of standard of care therapies on anti-tumor immunity and to test the immune-based therapies in head and neck cancer. As a nationally recognized expert in cancer immunotherapy and clinical research, Dr. Sikora is a member of the U.S. National Cancer Institute, Head and Neck Cancer Steering Committee, the NRG Oncology Cooperative Group Head and Neck Cancer Core Committee, and frequently serves on the U.S. National Institutes of Health grant review panels. And we are very grateful to have you here today as well. So we'll start with our questions. Lots of education there. So first of all, what is, very, very easy, what is immunotherapy?
So immunotherapy is really training your body's immune cells to identify something that you don't want in your body. Today we're talking about cancer, and using that as a way to treat the cancer, not only the cancer you have now, but the potential cancer that could recur later. Because once you've trained those cells to identify that cancer, they're in your body sort of running around looking for. And when we think about treating cancer, these are, today the modalities that we have, to give to and offer to our cancer patients. So surgery, of course, and that's, one of the things that I do for a living, so I put it at the top, but they're all equally important despite that. Radiation therapy, chemotherapy, targeted therapy, which is identifying molecules on the cancer that can be specifically targeted by drugs that activate or inactivate those molecules. And then finally, immunotherapy. And it's funny, 5 or 10 years ago, I'd put up a slide like this, and I'd go through these first 4 therapies, and then I describe immunotherapy as something that we were really hoping would join the list. And today, in 2019, immunotherapy is on the list, even if you can't see it because it's down at the bottom. So
Go ahead and use that.
Absolutely.
Okay.
So immunotherapy actually is an approved therapy for an increasing number of cancers every year. And so these are really the tools that we have to treat cancer patients. And one of the things that I think is important to emphasize is that not only can they be used separately, but they can be used together. And when we talk about bringing immunotherapy to cancer, we're not just talking about maybe replacing these therapies, but we're also talking about how to make those therapies stronger by bringing immunotherapy into the mix. Next slide, please. So your immune system actually, basically starts at the top of your head and ends at the bottom of your feet. So your immune system is really all over your entire body, and it includes specialized structures, like your tonsils, your spleen, other parts of your body that, their job is kind of to be like, the barracks, where your soldiers of the immune cells live, and they get exposed to the things that they need to learn to identify. Next slide. And the immune system is composed of cells, like everything else in your body. But unlike a lot of different cells in your body, the immune cells are constantly circulating through your body. So really, literally, every inch of your body is patrolled by these immune cells. And some of these cells up here, you might remember from science class, things like macrophages and T cells, those are kind of the popular immune cells. They have probably Facebook pages and things like that. And then, there's like, the neutrophils and the NK cells or natural killer cells. Maybe they're not so popular, but, they're important too. And, the point here is not that you need to memorize what these cells are, but you need to know that there's this little army of little white cells inside your body. And those cells, are what we talk about when we talk about the immune system, and those are the cells we're targeting when we talk about immunotherapy. Next slide. And one of the points I really like people to understand, because first, before we talk about how exciting immunotherapy is, I want you to think about just how hard it is and how almost impossible it sounds. Immunotherapy is literally hand-to-hand combat between those cells of your immune system and the tumor cells. And this is a beautiful example. This is a picture that was taken by my colleague Rita Serta of cells from our laboratory. The big ice cream cone or the big ice cream kind of looking thing is actually an oral cancer tumor cell in a petri dish. And those 2 red cells, they're not really red, but Rita made them red so you can see them. Those are T cells that have been educated to identify those tumor cells. And look at that. They found the tumor cell, they've latched on, and they're in the process of killing that cell. So immunotherapy is literally hand-to-hand combat. The same thing that happens in the petri dish happens in your body. And so now you're thinking, well, how is that going to work? If you think about all those cancer cells in a patient's body, how's that going to work? I'll tell you. Next slide. So whenever we talk about big numbers, whenever we want to really impress somebody with how big something is, we go to astronomy, right? Because nothing's bigger than the universe. And you think of something like, oh, too soon. So you think of something like, a galaxy, like this is like an average size galaxy about the size of our own Milky Way galaxy. And you think of all the stars in the galaxy, it's like you can't count them, right? There's so many stars. But, next slide, please. There are more immune cells in your body than there are stars in the galaxy. Think about that. And if you could get even a tiny percentage of those cells interested in something, you would have an incredibly powerful force. And that is the point of immunotherapy, is trying to get those cells to focus on the thing that we want to eradicate, which of course is cancer. Next slide. So the point here is that all the cancer therapies that I talked about, they all actually have an important role to play. I do feel a little biased, not just in favor of surgery, because surgery is really fun, and I enjoy doing it, but also I'm a little biased in favor of immunotherapy as a scientist. And the reason why is because many of you probably know that cancer cells are your own body cells that have mutated. They basically mutated, and what they're doing is they're constantly changing, so that when you throw a therapy at those cells are always changing and figuring out, how do I evade a therapy? So you treat a tumor with chemotherapy, and 99.9% of those cells disappear, but then there's a couple cells left because they figured out how to beat the chemotherapy. The thing that's special about immunotherapy is that the immune system is one of the systems in your body that actually evolves in real time. So you're not born with a particular set of immune cells, but they actually change and reshape themselves, and they can keep up with the cancer, so that long after many other therapies might have stopped working, the immune cells are still working, and you get something that we call a tail in the survival curve, so that the patients, instead of ultimately dying, a small number of those patients benefit from immunotherapy for a long time, and that tail of surviving patients can go out, for years, decades, in some cases, can be cures. Now, that's the really exciting thing. The thing that, as a researcher, I think is equally important, though, is to understand that only a small number of patients today benefit from immunotherapy. So we have amazing tools, but those tools still only benefit a small number of patients. And where the research comes in, and where the research into immunotherapy becomes important, is trying to think about, how do we take that small number of patients who get fantastic benefit from something like immunotherapy, and how do we bring that tail up? How do we extend those benefits to everyone? Next slide, and I think we're almost done. So when I think about immunotherapy, it's almost impossible, even as a very, very peaceful person, it's almost impossible not to use war and military metaphors. So I apologize for that, but it's just impossible not to. And what immunotherapies do is typically they use one of a couple basic approaches. One is taking the immune cells that are already in your body and stimulating them to identify cancer cells, learn to recognize them, and then to go find those cells and kill them. And that's basically similar to when the government sends military advisors over to another country, to go train that country's soldiers to find terrorists and root them out, for example. The other basic strategy is to actually take out the cells, educate them outside the patient's body, expand them, create huge numbers of immune cells in a test tube or in a dish, and then put them back in. And that's basically kind of like sending in the troops. So we call that adoptive cell therapy. Some of you may have heard of CAR T-cell therapy, therapies like that, where you're actually putting immune cells into the patient. That's what that is. And then finally, and my favorite sort of strategy, is figuring out how the tumor cells are evading your own body's immune system, which is constantly there patrolling and looking for them, and figuring out, how do you evade the tumor cell's defenses? So it's kind of like being a spy, right? It's like figuring out how the tumor cells are escaping detection and foiling them. And that's reversing the tumor's sort of cloak of invisibility, and that's where things like checkpoint, and I know you can't see all the slide, but basically we're talking about things like checkpoint inhibitors and other things that actually sort of like turn on the immune system's ability to recognize those cells. And I can't remember if I have another slide or not. I do. Okay. And it's an exciting one because this is basically all of what we're trying to do in immunotherapy right here in one slide. And if you look at the words kind of going down here, these are just some sort of buzzwords that can help you understand what's happening. But when we talk about immunotherapy, we're really talking about educating your immune cells to recognize cancer. We're talking about getting them activated so they have the weapons that they need to find the cancer cell and kill it, letting them penetrate into the tumor, evade the various very clever strategies that tumors have to turn them off, and then recognize the tumor and destroy it. And if it sounds complicated, it is. And it's amazing that so many years of research by people like, I'm sure everyone in this room has heard of the recent Nobel Prize winner James Allison, and of course all the many, many people who worked with him and with other researchers to bring things like checkpoint inhibitors through the whole process to patients. We can actually unleash this cycle and use it to benefit cancer patients. And with that, I'll stop talking, and I'd love to hear your questions.
Okay, well that was very informative, and you made it very easy, I think, to understand, especially with the slides.
You had the hard words.
I do have the hard words, that's right. So I think you did answer that as far as what are some of the different immunotherapy approaches being used to treat cancer in one of the slides, didn't you? That we did cover that. I don't know if you want to just pinpoint it and do another quick, what are some of the approaches?
Yeah, I think that's worth emphasizing because that's, often, yeah, what are we actually talking about? And, immunotherapy can mean a lot of different things. I'm gonna sort of focus on what are things that we actually have some sort of FDA approval for in some sort of cancer, because that narrows things down, because there's a lot more research going on than, we can, at this point, bring to cancer patients. So there are strategies to educate your own immune system to identify and find the cancer cells, and these can be things like cancer vaccines. So you would vaccinate the patient in order to educate the cells. There's adoptive cell therapy, which is basically creating tons and tons of highly activated immune cells outside the patient's body and then putting them in. And then there's ways of basically unmasking the tumor or basically unleashing the immune system's ability to find the tumor, and those are things like checkpoint inhibitors, things like anti-PD-1, anti-CTLA4, antibodies that interfere with the tumor's ability to shut the immune system down.
So if your body's immune system can be activated to kill cancer cells, why isn't that already happening?
So that's a good question. So if your immune system is so powerful, why do you have cancer, or why does a patient have cancer? And really that gets to that third mechanism I talked about, which is figuring out how tumors are able to evade the immune system. The tumor inside your body, it's able to create an environment around itself. When we think of a tumor, we tend to think of the actual cancer cells as being the only thing in the tumor, but actually a tumor is made up of cancer cells. It's made up of cells, just normal cells in your body that the cancer cell kind of like pulls around it to help nourish it, help protect it, and actually immune cells. But the problem is that the cancer figures out how to reprogram those immune cells so either they don't work or they actively suppress the other immune cells. So what the tumor does is it actually creates kind of a fortress around itself. And as long as it's inside that fortress, the immune cells of your body either can't get in, or they get in and they get killed, or they get inactivated. And that's how, even though your body might be full of immune cells that theoretically could get rid of a tumor, if they can't actually get to the tumor and stay active, that tumor is going to continue to grow. So a lot of what we try to do when we think about immunotherapy is figure out how to block those mechanisms the tumor uses to create that fortress and let the immune cells in.
I saw something in the news recently about immuno-oncology. And so what is the difference between immunotherapy and immuno-oncology?
So that's a super easy question, which is that they are the same. And what I mean by that is that they're really two words. One is a little catchier. Immuno-oncology is a little bit of a newer word. It's a little catchier. Those of us who've been in the field a while tend to call it immunotherapy, but they both mean the same thing. So when you're reading a news article or talking to your doctor and they use one word, immunotherapy, or another, immuno-oncology, they're talking about the same thing, activating your immune system and unleashing it on the cancer.
So you say you've been talking about this for a while. Just how long has immunotherapy, how long has it been out there in the medical field?
So that's a great question. So like a lot of things that seem to be really, really new and cutting edge, immunotherapy is actually well over 100 years old. And what I mean by that, so don't get me wrong, it's only been recently that immunotherapy has become successful and standardized to the point where it's actually entered routine patient care, and that's exciting. But literally over 100 years ago, more like 150 years ago, there was something called Coley's toxins that were created by actually a surgeon in New York called William Coley, and he realized that patients who had an infection at the same time they had a tumor would often see their tumor regress. That tumor would often go away. He got interested in that, and he would actually basically take bacteria, kill it, inject it into tumors, and in some cases, the tumors would regress. Now, the state of science was different back then than it is now, and, things were not as rigorous, and it didn't ultimately become a therapy that, sort of stood the test of time. On the other hand, we do things that are actually pretty similar to that in that we've identified some of the molecules in bacteria and other organisms that activate the immune system and then put them into immunotherapy. So in a way, even 150 years later, we're sort of still building on that legacy.
So if immunotherapy is so exciting, why do many patients still get treated first with surgery, chemotherapy, or radiation?
So that's a really good question. If we're so excited about immunotherapy, why do we still use these tools? And the short answer is because they work. So many patients can be successfully treated, particularly if they have early stage tumors with surgery as a single modality. So you get surgery and you're cured. Other patients respond better to multimodalities surgery or therapy, whether that be chemotherapy and radiation, or the combination of surgery and radiation, or surgery and chemotherapy. Every tumor is different, but the point is that these tools still work. These are still good tools for addressing cancer, but they don't work for everyone, and they have toxicities, and they have side effects. And the goal of bringing a new type of therapy, immunotherapy, into the mix is to bring a cure to those patients who we currently can't cure with our available tools, and then to see if maybe we can alter the profile of side effects in a way that we can cure patients and be less hard on their bodies.
So do you go first to the surgery? I mean, how do you determine whether you're going to go to immunotherapy?
Every tumor is different, and so in the current era, immunotherapy is mostly used for tumors that have failed other therapeutic approaches. They've been treated with surgery, chemotherapy, radiation, maybe all three. But one of the things that's exciting to me as a researcher in the field is to think about how we can move immunotherapy earlier in the treatment sequence and maybe spare patients some of the side effects of those therapies, which are really effective, but which can have very real effects on patients' quality of life.
Are there side effects with immunotherapy?
Oh, well, I guess I have to answer that question since I just talked about side effects. And the answer is, of course. I mean, there's no therapy that is effective and actually works that doesn't have potential side effects. And the side effects of immunotherapy can be significant. So basically, what you're asking the body to do, or you're asking your immune system to do, is to get very, very activated and be on continuous alert, and then tell the difference between the tumor and the other cells in your body that aren't tumor cells. And what you can get are side effects that are related to overactivation of the immune system. And they can be potentially severe. However, in general, they're, for most patients, they're milder than some of the side effects we can see with things like chemotherapy and radiation. They also have a different side effect profile. So in other words, the types of side effects we see with chemotherapy, radiation, conventional treatments are different from the ones we see with immunotherapy, which means that those combination, we might actually be able to combine them to create therapies that are very, very effective, but which the patients can still tolerate. Their bodies can still withstand that therapy.
So is it true that most patients treated with immunotherapy are cured? You see that on the news, I mean, it's out there, people talk about it.
So that's a good question. Some patients are certainly cured, but if you remember that graph I showed you that had, patient survival, and you have that tail of patients who are surviving. Not everyone is in that tail. So let's say today, let's say 15 or 20% of patients might get cured by immunotherapy. Keeping in mind that these are usually patients who have failed, our best conventional therapies before they even get to immunotherapy. But there's still an enormous number of patients who are not benefiting from immunotherapy today, and we need to continue to look for new mechanisms to target, new ways to select patients most likely to benefit, so we don't, treat the patients who don't benefit, and we focus the treatments on those who will, and try to get that survival curve higher and higher and higher every year.
So what is the difference between receiving immunotherapy as standard of care and as part of the clinical trial?
Right. So when we talk about standard of care therapies, we're usually talking about therapies that have been already approved by the FDA. So in other words, they've gone through the very lengthy process of clinical testing and validation, and the FDA has said, this is an appropriate therapy for a certain tumor type. And so, when we talk about standard of care immunotherapies, these are therapies that have been through this process, and the FDA has approved to be used in routine clinical treatment. When we talk about a clinical trial, we might even be talking about the same drug that's approved for one cancer, but now we're testing it in another cancer, or now we're testing that drug in combination with another drug to make it more effective. And a clinical trial is basically taking this new therapeutic approach and rigorously testing it in such a way that we can treat patients with it, keep track of what the side effects are, how well it was tolerated, and then have a very, very precise idea of who it benefited and who it didn't. And then that's the information that's used to decide, is this going to be a therapy that will be approved, sort of on a routine basis. And so that's, the difference between a standard of care therapy and a clinical trial.
What kind of patient would be a good patient for clinical trial? Can you determine that when they come in, or?
Yeah, as someone involved in clinical research, I feel almost every patient, should at least be aware and should know what clinical trials are there for your disease. But clinical trials are important because, number one, they give patients access to new and potentially effective therapies, as early as possible. Number two, some patients, like we mentioned a few minutes ago, some patients go through all the standard of care therapies that we have. They've had radiation, they've had surgery, they've had chemotherapy, we've run out of conventional therapies. A clinical trial gives them a chance, another chance to have some sort of treatment. And then finally, clinical trials are really the scientific method we have to determine what is an effective therapy and what is going to enter, routine clinical care. And so for all those reasons, patients sign up for clinical trials, not just because they think they themselves may benefit, but because overall, they're also benefiting medicine and future patients.
Well, do they have immunotherapy clinical trials at Baylor currently?
Right. So certainly at Baylor College of Medicine in the Dan L. Duncan Cancer Center, we have clinical trials of immunotherapy, both new agents, also combinations of immunotherapy agents, and combinations with standard of care for different tumor types. And I believe that's true probably for most of the different institutions at the Texas Medical Center. Those of us who live in Houston are really, really fortunate to just be surrounded by a sea of amazing cutting-edge medical care. And one of the really wonderful things about being in this area is you don't necessarily have to cross the country to be in a clinical trial. You might have a clinical trial right next door. And that's one of the really exciting things about living here.
So how is immunotherapy actually delivered? Pill, injection, how does that work?
So it depends. So depending on the type of immunotherapy, it may be delivered differently. However, the majority of immunotherapies that we use today tend to be what we call an infusion. So that's an intravenous injection that you might be given, for example, in a hospital. It might be given to you as an outpatient. So you might be able to show up, get treated, go home, come back next week, get treated again. Or for certain therapies or for certain conditions, you might be admitted to the hospital, treated, and then released later. Depends. But most of the currently available immunotherapies are given as an infusion intravenously.
I think you kind of answered this earlier, but are all cancers equally responsive to immunotherapy?
So that's a question that I'm sure is on people's minds. So immunotherapy has the potential to treat all different cancer types. However, not all cancer types are equally responsive. And we know there are certain cancer types such as melanoma, head and neck cancer, the cancer that I treat, bladder cancer, and so on and so forth, that tend to be responsive to immunotherapy. So there's something about that tumor that tends to make it potentially a good a target for immunotherapy. There are other tumors that are less responsive, and that probably, there is some immunotherapy approach out there that would work, but they're more refractory, and they tend not to be as responsive. So a lot of what we do, as researchers, and this is actually one of the particular research areas that I like to focus on, is kind of getting under the hood with different cancers, understanding why a certain cancer type or, a certain cancer, that a patient has might be resistant to immunotherapy, and how can you sort of outthink the cancer and make it responsive.
If only a minority of treated patients respond to immunotherapy long term, why is there so much excitement about it?
Well, that's a fair question. So one of the points that I thought it was important to make is that immunotherapy is exciting, but in the current day and age, only a small number of patients are benefiting from it. And I think it's important to make that point, not because I want to be like a wet blanket or, Debbie Downer, or, sort of have everyone leave here depressed. You shouldn't leave here depressed. You should be excited at all the, amazing advances that have been made over the past decade. But you hear so much on TV, on the news about immunotherapy. There's a lot of direct-to-consumer marketing, so there's a lot of marketing to actual patients, not even to their physicians, that are talking about how exciting immunotherapy is. You have to understand that in this day and age, immunotherapy is incredibly exciting and gives amazing benefit to a small number of patients, and we still have a ways to go before we're seeing a treatment for every patient that works. And so I think there's a lot of, you ask, why is there so much hype? Why is there so much excitement? Because we really went, in a very short amount of time from having no approved therapies to having a lot of approved therapies for a lot of cancers. And if we can just keep that curve going by putting in the hard work and the research that takes to continue that level of advancement, then, 10 years from now, I might be saying something different. I might be telling you how excited I am that there's, a therapy for almost every type of cancer.
Well, we talk about what's going on here in Texas and right here in Houston, but what about overseas in the world? Have you touched base with colleagues around the world about immunotherapy and what's next? What's the future? And I mean, you just talked about in 10 years, but like maybe in the next couple of years, what do you see coming at this point?
Yeah, so in terms of the first part of that question, is immunotherapy something that's happening around the world? The answer is yes, actually. So a lot of the research is being done here in the U.S., but a lot of it is being done in Europe. I had the pleasure to present at a immunotherapy meeting in Germany a year or two ago, and I was astonished at some of the cool science, that was going on over there. And in other parts of Europe, Asia, immunotherapy is big in Asia, and in fact, some of the really kind of exciting clinical trials are coming out of companies from there. So immunotherapy really is something that's catching on all around the world. In terms of what's next, in terms of the future, so I kept saying over and over that we need more research and we need to make it better, and that's true. So what kind of research is that going to be? I think one of the big trends is combinations. So if you think about it, cancer cells are pretty good at defeating any one thing you throw at them, right? Because they mutate and they have this ability to change. So one of the strategies for dealing with that is to take different immunotherapies or other therapies and combining them in rational ways that can sort of like get through the cancer's defenses. And this can be a combination of two different immunotherapy agents, or it can be a combination of immunotherapy with radiation or with chemotherapy, even with surgery. So I think figuring out for every tumor type which combinations are going to be effective is a big part of it. The second thing is identifying new targets. So, imagine you go into your garage, you pull out your toolbox, and all you have in there is a screwdriver. Well, you can do some stuff with the screwdriver, but you can't do everything. And that's kind of where we're at with immunotherapy. We need to go into the garage, pull out our tool chest, and find, a saw, a hammer, a screwdriver, a tape measure, so on and so forth. The more targets we identify, the more drugs we create that can target those different molecules, the more tools we have, and the more likely that a particular tumor will be responsive to something that we have in our tool chest.
Very easy for us to understand and talk about. Take very complicated subject and make it very easy. Appreciate that. At this time, we would like to open it up to questions in the audience. If y'all have any. Oh, tons of hands back there. Sure.
I'm ready. Actually, while you're distributing the microphone, I just want to say, I drove up here and I saw, dozens and dozens of school buses lined up, and I thought, this is fantastic. I'm finally getting the audience, that I've been looking for my whole life. So it's really, really nice to be here.
They're just a little older than the school kids.
Hi, my question is there something we can do with diet and lifestyle to help our own immune system maybe not get cancer?
Right. So we've been talking about all sorts of fancy drugs and the products of research and so on and so forth, but are there simpler everyday interventions that can make your immune system stronger? And the answer is almost certainly yes. So whenever we talk about things like diet and lifestyle, the answer is yes. Your immune system is certainly responsive to your diet, the kind of exercise you do, your quality of life, your level of stress, so on and so forth. And we can't always quantitate exactly what those relationships are, and those studies are really hard to do. I do the easy kind of studies where, I can treat mice with something and, test whether it works or it doesn't work, or I can test something in patients. Those are easy studies to do compared to the people who have to figure out how your lifestyle and how your diet affects your health. So certainly, everything that you just mentioned is a big part of keeping yourself healthy and cancer-free, but then also for patients who get cancer, that's something that we try to emphasize is, try to, get your quality of life and, get your diet and your exercise level up, to wherever you personally can get it to, and that's going to help your body fight the cancer, even if we don't know exactly how or how much.
About age, as far as is immunotherapy a better therapy for a certain age group? Have you explored that, or is that an issue at all?
So that's an interesting question. So I actually have to think about that question, which isn't fair. But I would say that we don't think so much of an age restriction on immunotherapy, but we do know that as all of us get older, our immune system gets weaker. So some types of immunotherapy might have to be a little stronger, if we're talking about older patients. On the flip side, because the side effect profile can be a little more forgiving, there may be patients who can't tolerate chemotherapy and, aggressive conventional therapies who could still benefit from immunotherapy. And actually, one of the things I talk to my colleagues about a lot is, well, maybe we should be thinking of trials in those patient populations, those older patients with a lot of comorbidities, with a lot of different different diseases, who can't get chemotherapy, maybe that's an age group that we should actually, instead of avoiding in clinical trials, maybe we should actually be focusing certain trials on them. So that's a really good point.
I have several questions. First of all, which specific cancers does immunotherapy work better on? And have you had any clinical trials with maybe animals or whatever that which ones does it work better in animals? Because it sounds like what you were saying is that the immunotherapy is only used when everything else runs out, when the patient is really sick. So you have any data on if it's used in a
Like an earlier setting?
Earlier, yes.
Yeah, so that's a good set of questions. So in terms of which cancers respond better to immunotherapy, I mean we learn more every day, but there is this list of cancers like lung cancer, head and neck cancer, melanoma, bladder cancer, certain types of colon cancer, that we know are good, tend to be good responders. Now that doesn't mean that every patient who has those cancers responds. It means that statistically you're more likely to have responders in those tumors than some other tumors. Now, that's the case, but that doesn't mean that other tumor types can't be made susceptible to immunotherapy. So I don't want to, sort of make it sound like there's only a small number of cancers that we should be studying, with respect to immunotherapy. In terms of the question you ask about, what does it mean that we tend to treat advanced cancers or recurrent cancers, or the really bad cancers, with immunotherapy? That's a little bit, in some ways, sort of an artifact of the process we have for testing and approving new therapies. And in a way, it's very safe in the sense that, the FDA, the Food and Drug Administration, that is ultimately responsible for approving therapies, they don't want people to just start treating everyone, particularly if there are tools like surgery, chemotherapy, and radiation that might be effective. So in order to test therapy, you have to show that, you have to have kind of a certain number of studies that show safety, and then usually you have to start testing the patients who don't have other good therapeutic options, because if they did, they should probably get those rather than kind of roll the dice on a new therapy. So we tend to take new therapies and first bring them to patients with metastatic disease, with recurrent disease, the really bad disease. However, once you get a track record in those diseases, you can start thinking about, well, what happens if we start moving therapy up earlier in treatment and treat earlier cancers or less refractory cancers. And with immunotherapy, some clinical trials, for example, will administer a checkpoint inhibitor or another immunotherapy agent, and then bring the patient to their standard of care surgery. So if it's a patient who is going to get surgery anyway, they'll be administered an immunotherapy and with the plan to then resect their tumor. But in some cases, there's no tumor to resect. And what that tells us is that, there really is hope that as we keep bringing immunotherapy earlier and earlier in, the course of cancer, that it might it might actually be something that's really effective. But the only way to know that is to do the trials, to get the data, and that's what's going to drive the science forward.
Thank you, Dr. Sikora, for your presentation and being several your lecture. I would like to ask you, how early is the best way to start immunotherapy? I mean, you start with surgery, chemotherapy, or you attack the disease immediately? The second question is, I'm from Ecuador, and I refer a lot of patients to different hospitals here. How expensive is still immunotherapy?
How expensive was your second question?
Yes.
Okay, let me answer the first question first, and then the second one. So the question is, when should immunotherapy be administered? And sort of, the sort of along the same theme of what we were just talking about. In today's state of the science, we tend to give immunotherapy after other therapies have been exhausted. So the patients have been treated with, the standard chemotherapy or radiation or whatever that conventional treatment is. The tumor comes back or it persists, and then they get immunotherapy. So that's administering immunotherapy kind of late in the game. It may actually be more effective to treat patients earlier, maybe before surgery, maybe even in some cases instead of radiation plus chemotherapy, maybe they could get radiation plus immunotherapy. There's clinical trials testing this. And so for every tumor, there might be a different rational sequence and sort of order of treatment to get. And that's, part of what our job is as clinical trialists, is to try to sort that out for the different tumor types. With respect to expense, I'm actually really glad that you brought that up, because I do think that that's an important point. And like many new treatments, immunotherapies tend to be expensive. So what do I mean when I say expensive? So I'm not going to talk about particular drugs or particular costs, but a full course of immunotherapy can be hundreds of thousands of dollars, many hundreds of thousands of dollars. And obviously, if you're the patient that's treated, that's money well spent. But we think, even as physicians, we think both in terms of treating the patient in front of us, and then we think in terms of, the social good, and we think of public health, and we think about, sort of how are we going to continue to bring the benefits of immunotherapy to as many people as possible, given that they're so expensive. Now, you leave the United States and things really change. So in the developed world, parts of Asia and Europe, that have good healthcare delivery systems, they're going to have access to these drugs the way we do. But then there are parts of the world where immunotherapy might be kind of far off, because they're at a different level of development. And so something, sort of an open challenge to the community, of people who study immunotherapy is figuring out how can we reduce the costs. So how can we either repurpose existing agents that have immune effects that have already been developed, so you don't have that fantastic cost of developing a new drug? How can we develop tools that identify the patients who will benefit, so that when we do spend money, we're spending it wisely and we're not spending it on patients who don't benefit? And then, are there maybe, therapies that we don't think of as immunotherapy, but that have immune effects that with just a little push could be made more effective. Maybe not, maybe you don't need a new drug. So one of the things that my lab studies is radiotherapy, which has, massive effects on the immune system that we barely understand. And we try to figure out, well, what are, if we just block a pathway here, or if we, get rid of a particular cell type, can the radiation actually induce the immune response that we want to eradicate the tumor? So I think there's a lot that we need to do to not only develop new therapies, but try to bring the therapies we have to everyone. And expense and cost is actually a big sort of awkward part of that conversation.
Hi, Dr. Sikora. I have a question going back to microbiology. Looking at that slide where you had the oral cancer and the T cells, how do you get those T cells to bind to that cancer cell, and how does the T cells then induce the apoptosis, the cell death?
Yeah, so the beauty, so to my mind, and I'm biased as an immunologist, so, it's sort of like if you talk to somebody who plays with model trains are the coolest, most beautiful thing in the world. I think the immune system is absolutely the most amazing thing in the world. And the key thing here is that the T cell is already a self-contained guided missile that has everything it needs inside of it to identify a tumor cell, lock onto it, grab it, and kill it. I mean, it's all there. It's all there. I don't have to invent that. I mean, the T cell that nature designed is pretty good at doing that, and all we do is we kind of tweak it a little, or educate it, or put it in the right place at the right time. So all those steps that you mentioned, of the T cell finding the tumor, locking onto the tumor, inducing apoptosis, which is kind of a fancy way of saying killing the tumor. That's what that is. The T cell knows how to do it, and it's really just a matter of getting the T cell through the tumor's defenses, to where it needs to be, and that's kind of like where the exciting part of the research is, the way I think about it. So, great question.
Doctor, if I recall correctly, the efforts on immunotherapy in the late 80s ran into a roadblock when a patient died suddenly. And the question came down, it was really clear that the therapy techniques are dependent upon a thorough understanding of the inflammation response, which is, I understand, a whole universe of issues that I was just curious as to where you feel we stand today on that bigger mechanism that the T cells and the like participate in, clearly.
Yeah, so what you say is true in that there are patients who have died in clinical trials of immunotherapy both in the 80s and since, and the key points that I like that sort of make sense to me are every therapy that's potentially effective is also potentially harmful, to the wrong patient or, in the wrong situation. So we're always trying to balance the benefits of therapy with the potential harms, the potential side effects, so on. Clinical trials, although exciting and although really, really important, are not without risk. And one of the really important things you do when you talk to a patient about entering a clinical trial is you talk about those risks and you have a very honest conversation so they can go in there, understanding that yes, they may benefit, yes, they may get this exciting cutting edge therapy, but we don't know everything about it. And then that brings us to that final topic you brought up, which is sort of like, inflammation or, the possibility that your immune system will turn against your body, is I think sort of where you're headed with that. And of course, as we activate the immune system, we increase that risk. So the good news is that as much as, a lot of our research is focused on, what I talked about before, identifying new targets, identifying better ways to use the tools we have. Also, there's research focused on understanding what are the side effects of immunotherapy. There's actually specific, grants that I'm aware of that, are trying to promote people to study that. So they're actually trying to encourage people, both in animal models and also in actual patient samples, to understand, well, when patients do have side effects, how is that happening and how can we reduce them? And in fact, if you look at sort of the history of immunotherapy, to make a long story short, we have gotten much better at managing side effects. So side effects that would be terrifying, 10 years ago are kind of routinely treated today, not by me, but by the smart people who do that type of therapy. And, I think that's, a part of the puzzle is understanding not just how the therapies work, but how they go wrong and how we can fix that. Y'all have some stamina. I'm impressed.
Hi, thank you. What's actually in the serum? Is it just T cells? And if so, where are they from? Or are there vitamins or anything in addition?
So when you say serum, you mean like in your blood or in a treatment?
You said you inject?
Okay, gotcha. So it depends on the therapy. And so different therapies actually have different active components. So, if you look at something like checkpoint inhibitors, like, for example, anti-CTLA-4, the agent that recently won the Nobel Prize, that's actually an antibody. So that's actually a molecule that is actually in your serum right now. It's actually in your blood floating around. And what they did is they figured out how to find the right antibody that binds to the right molecule and just make a whole ton of it in a petri dish and then put that into people. Other immunotherapies, the active ingredient is actually cells. So you're actually putting cells into people. Others are drugs, what we call small molecule inhibitors and, other types of agents that maybe work, with another therapy to activate the immune system. So basically, it depends on what you get, which is why you should always read the label before you take anything. Always read the label.
Thank you for being here. My question is for cancer patients on immunotherapy that have gone into remission. What is the logic behind a physician deciding when they should stop with the therapy because the cells have been educated and they're good to go on their own, versus kind of continue with the immunotherapy post the remission? What is the logic behind that process?
Yeah, so I love that question. And the reason I love that question is because I have absolutely no idea what the answer is. And, you know, I sometimes feel bad when I don't know the answer for something, but in this case, nobody knows the answer. And what you bring up is actually very related to the question from this side of the room about cost, right? Because you can imagine if we continue in immunotherapy indefinitely, the costs are going to be much higher than if you can just, you know, get the drug in, activate the immune system, you know, and move on, right? And so these are the sorts of things that are actually being studied in clinical trials. Both, is there a role for, you know, what we call maintenance immunotherapy, so continually dosing patients for, you know, potentially a really long time, you know, with an agent, or conversely, you know, can we take an agent that we're continuing to dose patients with because, you know, we're terrified to stop because we don't know, you know, what's a good stopping point, can we stop it, and what happens? And, you know, these are the kinds of things where you can really only answer them with clinical trials. There's no other good way to kind of think your way around it. And they're incredibly important because, you know, as we just talked about, you know, these therapies are exciting, but, you know, we want them to be viable for as many people as possible, and we want to make them as cost efficient as possible. And these are the kinds of questions we have to answer. So I didn't answer your question, but it is a very active question in the field, is trying to understand that.
Wait, what are the elements of cost? I mean, what's contributing so much? Is it because of the long process of FDA approval? Is it the branded drugs once they're approved? It's not generic, and so the drug companies are making a lot of money on that. How can we as a society help lower the costs?
Yeah, so you know, yeah, again, I'm really excited to hear you know, these questions, you know, these very practical questions about cost. And I want to kind of take a middle ground between being an apologist for industry and being a conspiracy theorist. Okay, so I'm trying to figure out what's the middle ground. And the fact is, so it takes about 12 to 18 years from when a scientist in a lab discovers something to it actually being like an FDA-approved therapy. And so that's thing one. So that's a long time. You can imagine, you know, every one of those years is expensive. Thing two is that if I say, and I can't remember the exact statistics, but, you know, if you say take 20 potential therapies, you know, that start out being really exciting in the lab, if one of them makes it into, you know, clinical practice, those, you know, that's awesome. You know, so many therapies are developed sometimes all the way up to phase 2, phase 3 clinical trials. They look promising, and then, you know, they didn't work. And so, you know, you can imagine all that, you know, effort that went into developing something that's now wasted. So that's kind of a convoluted way of saying, you know, part of the driver of cost is that it genuinely is expensive to develop new drugs. Like, it really is. Like, you know, I get that. However, you can imagine you've invested all this time and all this effort and all this money into developing a drug. You're probably not going to give it away. And you're probably going to figure out, how much can I actually charge before people stop paying? And this is a much harder part of the equation. You know, is it the role, you know, do we want that decision to be made by insurance companies, you know, by what they will and will not cover? Do we want that decision to be made by the government? You know, do we want there to be lists of things that are covered, things that are not, and how much they can be, you know, sold for? Do we want the market to decide? I don't necessarily have the answer to those questions, but I think they're incredibly important, and they need to be part of a conversation that doesn't just include doctors, insurers, and government. They need to be part of a conversation that includes the people, you know, the patients, the caregivers, the family members, all of us who are potential cancer patients at some point in the future. I hope not, but, you know, statistics are what they are. So I think these are tough questions, but there's a lot of things that drive the cost of immunotherapy, some of which are probably unavoidable, like the costs of development, and some of which probably could be modified if we figured out what we as a society think is important to pay for and how.
All right, so we have some online questions from our social media platforms. Don't forget to follow us at the Women's Fund on Twitter and Instagram, and the Women's Fund Houston on Facebook, which is where you'll find the video of this talk. The first question is, what type of questions should you ask your doctor to see if immunotherapy is the best way to go?
Oh, wow. That is a really, that's a good practical question. So I think the first important thing is to, and it's interesting, I don't know where to direct my answer, but maybe I'll direct it to the internet. So, the first thing is to make sure that you bring it up. Hopefully your doctor will bring it up if it's an option, but you know what? It's great to have a belt and suspenders approach to life, and as long as you bring it up, you know that immunotherapy is going to be part of the conversation. So I think number one, it's important that the patient or the patient's caregivers or some combination, bring that to the table. And then, in terms of who is immunotherapy right for, who's it not? It's different for every tumor. It's different for every stage of tumor. That's where, you have to, have the honest conversation with your physician and find out if, number one, is there an FDA-approved therapy, right now for my cancer, in which case, that kind of answers your question, that at least it's an option. If not, is there a clinical trial? And once again, I hope that your physician is knowledgeable about the trials and brings them to you, but it doesn't hurt to look. It doesn't hurt to do your own research. And I realize saying that's not an easy thing to do if you haven't been through medical school, but there are online tools. One of them is called clinicaltrials.gov. So clinicaltrials.gov is a searchable database that's meant to be searched not just by researchers, but by patients and by other physicians. And then there's a group that I've had the pleasure of working with for many years called the Cancer Research Institute, or CRI, Cancer Research Institute. Their website has a ton of information, including practical information about where to find clinical trials.
Right. And one final question, since we're short on time. What do you think will happen or needs to happen in the medical field within the next 5 or 10 years to continue the advancement of immunotherapy?
Right. So how do we take the the recent exciting successes in immunotherapy? How do we keep that momentum forward? I'm really tempted to paraphrase Matt Damon in The Martian, who had something to say about the importance of science in survival and development. But what I'll say is that we really need to continue to do the research. So what we really need to do is continue doing research both at the very, very basic level, so laboratory-based research to identify the new targets, identify the new approaches. We need to be doing clinical research to take the tools that we have and figure out which ones work, who do they work for, how do we combine them in a way that's as effective as possible. And then, we also need to solve some of these really tricky questions that we've, been talking about in terms of who's going to get the therapies, how are we going to pay for them. Again, as a scientist, I feel like I get asked the easy questions. How does this work, and how do I make it work better? Some of those more kind of social questions are really hard. But if we can continue to make progress on all those fronts, we're going to continue to develop new therapies. We're going to bring them to our patients, and more people are going to benefit. And I'm really excited to think about what this talk might be like 10 years from now. I'm really excited to think about how much more, energy and enthusiasm there might be. Thanks.
Okay, thank you, Dr. Sikora. What a great presentation. I'd like to thank everyone for being here today, but I also would like to thank the John P. McGovern Foundation, who provided the funding for today's videotaping. Again, I want to remind you that this is live on Facebook. You can go back to Facebook. We're being both the Health Museum's Facebook page and the Women's Fund Houston Facebook page and see this video again, and then it will also be posted within the week on our website, www.thewomensfund.org. I'd like to thank Danielle Duncan Comprehensive Cancer Center and Baylor College of Medicine for lending us this wonderful expertise today. And also Deborah for taking time out of her busy day for being with us. And lastly, but not least, the Health Museum. What a wonderful partnership we have with them. In fact, we're already working on our next Doc Talk, and we're hoping to have another one in June of this year, and it will be another very informative and engaging conversation on a very hot topic, which we will disclose later through our Facebook page and the Health Museum's Facebook page. So with that, the only other announcement I have, if you enjoyed today's presentation, I do want to let you know that on Friday, May 31st, we will be having one of our membership luncheons at Tony's. There is a cost associated with that, $35 for our members and $50 for guests. And we have our guest speaker in the audience today, Allison Toperwine. She will be talking about, stand up, people are looking at you or for you. Allison will be giving a presentation on thriving with Parkinson's disease. So come hear from this two-time American Ninja Warrior about how she's doing this today. So with that, thank you for being here. We appreciate you very much. Thank you.
Thank you.